Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from RDEL-X.
Well, good morning and welcome. Thank you for joining us today for this Medscape Education event entitled Empowering Frontline Care in Irritable Bowel Syndrome Constipation, Moving Beyond Over-the-Counter Therapies. My name is Kimberly Carter, and I'm an associate professor and director of clinical education for the PA program at Midwestern University here in Glendale, Arizona. And I look forward to spending the next 30 minutes with you, kind of reviewing the pathophysiology of IBS, talking about the over-the-counter and prescription agents available to treat IBS-C, and really summarizing elements of a therapeutic clinician-patient relationship. So I want to start off first with a review of the pathophysiology. And it's important to understand that IBS has been reclassified from a functional bowel disorder to a disorder of gut-brain interaction, really reflecting our evolving understanding of the brain-gut axis and the bidirectional communication that occurs between the central nervous system and the enteric nervous system. And that's depicted by the image here on the left. The image on the right nicely demonstrates that there's no one single unifying etiology for IBS. It is complex, it is multifactorial, involves a biopsychosocial process, and really is a blend of host, luminal, and environmental factors. So I want to walk through some of these factors because they may predispose the development of IBS, but it also exacerbates symptomatology for patients. So we can see here genetic predisposition, GI infections. A patient may have had a previous Giardia infection and now a year or two later may be developing this post-infectious irritable bowel syndrome. Food sensitivities may play a role. We also know that an altered intestinal barrier, that increased permeability, can lead to immune activation and an inflammatory cascade. Altered bacterial flora, so the gut microbiome. And we also know, too, that serotonin and other neurotransmitters can affect GI motility, as well as chronic stress, psychosocial factors, so anxiety, depression, and even our cognitive, behavioral, and emotional responses to those things can aggravate symptomatology. And then, of course, the visceral hypersensitivity, that markedly reduced threshold to pain. All of these factors can predispose the development of IBS and exacerbate symptomatology. So it's important that we understand that. Another big feature that I want to share today is discussion about the positive diagnostic strategy. This has been a paradigm shift. IBS is no longer a diagnosis of exclusion, right? We know that as a diagnosis of exclusion with pursuit of advanced imaging and invasive testing delays the diagnosis, delays receipt of therapy, really does not reassure patients and can be quite anxiety provoking, is of low yield, and increases healthcare costs. So, a positive diagnostic strategy has really paved the way for clinicians to comfortably and confidently diagnose IBS. And it's inclusive of these 5 features here. So, taking careful history, which we'll talk about, performing a thorough physical exam, which includes a rectal exam, Applying symptoms-based criteria. So this is currently the Rome 4 criteria, although Rome 5 is to be completed here and released here soon in 2026. Assessing for alarm features. That's part of our thorough history. If those are present, certainly referral to gastroenterology. We want to make sure we're not missing something like colorectal cancer or inflammatory bowel disease like Crohn's or ulcerative colitis or celiac disease. And then lastly, classifying the appropriate treatments based on that stool pattern, based on that subtype. And that helps to dictate our management as well. So let's talk a little bit about the symptomatology. It's important to understand that irritable bowel syndrome is a constellation of symptoms. And the cardinal features of IBS-C is constipation and abdominal pain. And although bloating is not required for the diagnosis, not part of that Rome 4 criteria, a lot of patients have bloating and it's quite impactful and burdensome for them. It's also important to recognize that IBS overlaps with other disorders of gut brain interaction and often can coincide with other upper GI symptoms. In talking a little bit about the physical exam, certainly, generally, the physical exam is normal. It's benign. Vitals are unremarkable. They may have some non-specific tenderness in the lower abdominal quadrants, but it's really important that we're considering and performing a perianal digital rectal exam. And certainly, I understand providers thinking, well, this could be of limited value. It's underutilized. It's too sensitive, requires a chaperone, but is really quite helpful in understanding the mechanisms of defecation and can help kind of support or negate whether or not a patient may have dysenergic defecation. So, talking a little bit about the Rome 4 diagnostic criteria. Again, this is a symptoms based criteria. It really is outlining the frequency and the chronicity of symptoms. So, this is recurrent abdominal pain on average at least 1 day per week in the past 3 months, associated with at least two of the following criteria. So, this abdominal pain may be related to defecation. Maybe it precedes defecation or occurs after defecation. Maybe it's relieved with defecation or worsened by defecation. It can be associated with the change in the frequency of the stool and associated with the change in the form of the stool. And it's really important that when a patient communicates that they have constipation, we need to understand what that means. Is it infrequent bowel movements? Is it the passage of a hard pellet-like stool? Is it difficult to evacuate? Are they straining with defecation? Is there prolonged time on the toilet? That's really helpful in kind of how we're going to approach our management. And then this criteria is fulfilled for the last 3 months with symptom onset at least 6 months prior to diagnosis. So, again, as part of this positive diagnostic strategy, our history, our physical, our Rome 4 criteria, we also have to do our due diligence in inquiring and assessing for alarm features that could suggest organic disorders. So, in patients who have new symptoms, age greater than 45 to 50, we want to refer. If they have unintended weight loss, particularly 10% in the last 3 months, blood in the stool, hematochezia, bright red blood per rectum, nocturnal symptoms, constitutional symptoms, rapidly progressive symptoms, and then certainly family history of colorectal cancer, IBD, which encompasses both Crohn's and ulcerative colitis or celiac disease. Again, these patients, we want to query for alarm features and refer to GI appropriately. And then lastly, part of this positive diagnostic strategy is considering selective laboratory evaluation. A positive diagnosis can be made with limited testing. Not all patients require testing, not all patients require intensive testing. So, really, in appropriate patients, consider the 4 Cs. A CBC can be helpful for the assessment of anemia or leukocytosis. C reactive protein and fecal calprotectin can be quite helpful in distinguishing inflammatory bowel disease from irritable bowel syndrome. So, patients with inflammatory bowel disease may have an elevated C reactive protein and fecal calprotectin, which would not be the case in IBS. and then celiac serologies. So again, there's no good biomarker for IBS. So again, we're using this positive diagnostic strategy. What I would say on this slide is it's really important to remember that this selective laboratory evaluation is independent of performing our age appropriate colorectal cancer screening. So that's important to keep in mind. But the big take home message here is that we can make a positive diagnosis on symptomatology, limited testing, selective laboratory evaluation, and really aiming to initiate treatment, ideally at that first visit. So let's talk a little bit about the management of IBS. And really, this is two overarching goals to relieve symptoms, but also to improve quality of life. We know that irritable bowel syndrome is not associated with complications or sequelae of disease, but it can be incredibly impactful for patients, affecting them physically, emotionally, and socially. And a lot of patients have GI specific anxiety and hypervigilance. It may can contribute to work absenteeism, social isolation, and a lot of patients might create plans contingent on access to the restroom. So it's really important we understand the impact that it has on their life. So our three main approaches here, initially for all patients, absolutely dietary, lifestyle, and behavior modifications. And we'll talk a little bit more about that. Pharmacologic therapies, so over the counter and prescription agents, and the armamentarium of prescription agents has really grown for IBS-C. We now have four FDA-approved therapies from two different classes of medications. And then psychotherapies are brain, gut, behavioral therapies, and neuromodulators. And what I would say with those is that they really help to target some of that visceral hypersensitivity, facilitate coping mechanisms, and really help with some self-regulation techniques. But the other big piece of this is to incorporate an individualized multimodal approach supported by a therapeutic clinician patient relationship. And so, what I mean by that is that this is not a one size fits all, right? We need to understand what is most problematic for our patients. What have they tried? Where is there still a gap potentially in coverage of that symptomatology? We may need to combine therapies. But I think the continuity of care here is really important and recognizing that this is going to take some time. This is not, we're not going to be able to achieve everything on one visit. We're going to need some follow up care. And so that's kind of what this slide is speaking to is negotiating a mutual treatment plan for patients, involving them in the clinical decision making, understanding their preferences, their values, their challenges and barriers to the plan. Really encouraging questions. We want to make sure that they understand about about IBS and the pathophysiology. And really, that can help to increase compliance and follow up and setting realistic goals. Again, giving time for those therapies to take effect and really recognizing that multiple visits are going to have to be scheduled to kind of ensure that we can get things controlled. So, I want to just talk briefly to introduce the treatments for IBS constipation. And I think this is an excellent slide to just make sort of several summary recommendations here. So, we have our non pharmacologic interventions on the left, our lifestyle interventions, our dietary modifications like the low FODMAP diet, which we'll talk briefly about, over the counter therapies like osmotic laxatives, polyethylene glycol, peppermint oil, soluble fiber, and then probiotics. And we'll talk about each one of these. Down the center here, we have our FDA approved prescription medications. So, again, these are now classified. We have our secretogs, which include our linaclotide, lubiprostone, and placanatide, and then our retainagogues with tenapanor, first in class medication for retainagogues. And then the brain gut behavioral neuromodulator therapies, tricyclic antidepressants, SNRIs, and then the brain gut behavioral therapies owing to things like cognitive behavioral therapy and gut directed hypnotherapy. And then we have our clinical practice guidelines off to the right here. And this is inclusive of two large GI societies. So the American Gastroenterology Association and the American College of Gastroenterology. So let's talk a little bit first about some of the initial treatment approaches for IBS-C. And again, it's important to understand that A lot of patients may have constipation due to physical inactivity, sedentary lifestyle, or a diet that's low in fiber. It's highly processed, it's highly refined. So, encouraging physical activity, encouraging the patient to take a 20-minute walk daily can be quite helpful and help stimulating the GI tract. It's important with every visit that we're going through their medications, reconciling those medications, identifying agents that might be contributing and exacerbating constipation and hypomotility. So, thinking about anticholinergics and opiate medications and trying to limit the use of those offending medications. Diet and fiber intake. So, again, we're focusing here on increasing soluble fiber intake. So, that psyllium. Insoluble fiber may cause worsening bloating. So, we want to be mindful of that and really individualizing the use of those over the counter therapies. So, just a little bit more about those dietary lifestyle approaches. So, again, focusing on increasing fiber, aiming for 25 to 30 grams per day, starting low and increasing that slowly. We do know that natural laxatives are found in things like prunes, peaches, pears. So this all has sorbitol, which helps to kind of increase some of that fluid secretion. Stimulants, so rhubarb can be a stimulant. And then kiwi has prokinetic properties. So those can be sort of natural laxatives. And then lastly, the FODMAP restriction. So the low FODMAP diet. So that three-phase dietary approach where the patient eliminates, reintroduces, and then personalizes the FODMAP diet can be helpful. I will say for the low FODMAP diet, it can be helpful for pain and bloating, but less likely to be helpful with improving some of the bowel habits themselves. But it's important that we're conducting a dietary recall so we can assess that when these things are deficient, we're supplementing fiber, fluid, and exercise as appropriate to help control. Review of over the counter treatment agents. Again, psyllium fiber, most widely studied, strongly recommended by the ACG. It's inexpensive, creates sort of this gel like substance, and really can offer other health benefits like regulation of blood sugar and cholesterol levels. Osmotic laxatives, so polyethylene glycol. This can improve the stool frequency and consistency, but is comes a little short, falls short of reliably improving abdominal pain and bloating. And then the last is our stimulant laxatives. So Senna, Bisocorol. ACG makes no recommendations regarding stimulant laxatives. No randomized controlled trials have been done, but these may be helpful for the patient with an occasional infrequent bowel movement. Therapies with limited utility in IBS. So we already spoke a little bit about polyethylene glycol, and again, may be helpful for improving bowel movements, but less so for pain and bloating. Prebiotics, probiotics, certainly, I think, with the role of the gut microbiome in IBS, this has widely spurred interest in probiotics. But there's different strands and species and preparations and formulations, so it makes it more difficult to study. So I think it's important that if we trial a patient on probiotic, I tried probiotic rich foods if possible. And then antispasmodics like cyclamine, they may be helpful for postprandial pain, but less likely for that chronic pain. And certainly adverse effects, anticholinergic side effects, dry mouth, dry eyes, constipation may limit use. So let's talk briefly about the FDA approved prescription medications. And this is a great summary slide identifying the two different categories of medications. So our secretagogues and our retainagogues. You see the agents listed here on the left, followed by their FDA approval date, their mechanism of action, the dosing. And so linaclotide offers a variable dosing opportunities, and then the common side effects here, which is primarily diarrhea. As far as the mechanism of action, so when we're talking about our secretagogues, lubiprostone, lecanatide, they are all working to increase intestinal fluid secretion. So lubiprostone activating those chloride channels, linaclotide, plecanatide, they're helping to bind to the GCC receptor site and increasing that intestinal fluid secretion. And then we have tenapanor. This is a first in class, minimally absorbed small molecule, a retainagogue. So it's an inhibitor of the sodium hydrogen exchanger isoform 3. And so ultimately, what that's doing, it's inhibiting, blocking that dietary absorption of sodium. And in result, it retains fluid into the intestinal lumen, and that works to soften stool and accelerate transit. So, briefly to review some of the data for secretagogues, so this is inclusive of lubiprostone, linaclotide, and plecanatide. And certainly, on initial glance, you can see that a greater percentage of patients achieved improved abdominal pain and bowel habits with prescription therapies compared to placebo. And I think that's important to remember with these FDA approved medications is so this added benefit of improving their abdominal pain. So looking at lubiprostone first, so again, a greater percentage of patients achieved improved abdominal pain and bowel habits with lubiprostone 8 micrograms twice a day compared to placebo. Um, we can see linaclotide, again, two large studies here. Greater percentage of patients achieved improved outcomes with linaclotide 290 micrograms daily compared to placebo. And then again, too, with plecanatide, two studies here, greater percentage of patients achieved improved abdominal pain and bowel habits with plecanatide 3 milligrams daily compared to placebo. If we take a look at tenapanor now, similarly, again, greater percentage of patients achieved improved bowel habits or reduction in their abdominal pain and improved bowel habits compared to placebo. So, if we look at the safety of the prescription medications, it's important to recognize that these prescription agents, they're well tolerated. They have favorable profiles, similar safety profiles. And the most common adverse effect is diarrhea, but that's transient. And so we want to work through that with patients. So, again, well tolerated, favorable safety profiles. So let's talk a little bit about our considerations for over the counter therapy versus prescription agents. And I like to start here in the center. When we're working with our patients initially and throughout, it's really important that we understand what have they tried? What over the counter therapies have they tried? How long did they try them? What benefit? Maybe they had benefits in reduction or improvement in bowel habits, but less likely the pain and bloating. So it's important for us to understand what they've tried. And then really focusing on trying different over the counter agents. Generally, for 2 to 4 weeks, we want to make sure that we're giving adequate trials. So this may be psyllium based, and then we're adding on maybe polyethylene glycol. Again, those things may be helpful for the constipation, but maybe limiting when it comes to really targeting some of that bloating and abdominal pain. So I think it's important to consider a prescription if you have a patient that's given a single or a combined over the counter treatments, they've given those a fair trial and their symptoms still persist. So, I want to conclude with a discussion about the management continuum. And it's really important that, again, we're kind of following this cycle here of really listening to our patients, understanding their concerns, how it's impacting their quality of life, really educating on the diagnosis of IBS-C, ensuring they understand that pathophysiology, focusing on use of the positive diagnostic strategy, history, physical, Rome 4 criteria, querying for alarm features, selective laboratory evaluation. Again, extensive laboratory evaluation is not appropriate and really can delay therapy and it's of low yield. Really reassuring patients. Yes, IBS-C, it's a common condition. It's a chronic condition. There are going to be periods of exacerbation and periods of quiescence, but it does not impact mortality. It's not associated with the development of inflammatory bowel disease or the development of colorectal cancer. It can be well managed currently with available FDA therapies, and we have, 4 agents now to select. Common side effect diarrhea, transient, but we can work through that. And then really focusing on that treatment, that multifactorial pathophysiology, understanding the brain gut access and that bidirectional communication between the central nervous system and the enteric nervous system. Again, we have different medications, different mechanism of actions, and perhaps if one agent in a particular class doesn't work, maybe switching to another class of agents. May have had a patient who was on a secretog and maybe didn't get full relief or incomplete relief, and so maybe we're going to try tenapanor. So again, wanting to make sure that we're following this continuum for a successful office visit. And this is sort of echoing a lot of that as well, establishing and understanding elements of a therapeutic clinician patient relationship. So, again, this is really important that we're proactive and patient, that we're inquiring about bowel habits. We want to understand when a patient communicates that they have constipation, what do they mean by that? Is this infrequent bowel movements? Is it a passage of a hard stool? Is it prolonged time on the toilet? Really understanding that can help kind of then dictate our management for the patient. Actively listening and validating their symptoms, educating and reassuring it's a benign course, offering interdisciplinary support, utilizing that shared decision making, and again, really focusing on setting realistic goals and maintaining that continuity of care. So, in speaking about interprofessional collaboration, again, utilizing gastroenterologists, primary care clinicians, APPs, so physician assistants and nurse practitioners, initiating that positive diagnostic strategy. Dietitians can be quite helpful when it comes to utilizing and incorporating the low FODMAP diet. Is that three-phase approach and requires time-intensive counseling. But we want to make sure that patients are not over-restricting as well. And then behavioral health specialists, they can be quite helpful when we're talking about incorporating potentially cognitive behavioral therapies or potentially gut-directed hypnotherapy. A point on that is those are not as widely available. They are very time intensive and can be patient and provider dependent as well. So, keeping that in mind. So, just some concluding remarks here. It's important to recognize that, again, IBS is reclassified from a functional bowel disorder to a disorder of gut brain interaction, really reflecting that bidirectional communication and representative of a biopsychosocial process. And I think the more we understand about the pathophysiology, the more apt we're able to provide targeted treatment therapies for our patients. Um, there's been a paradigm shift, right? This IBS is no longer a diagnosis of exclusion. We can confidently and comfortably diagnose IBS using a positive diagnostic strategy, taking a thorough history, performing a physical exam, excluding alarm features, incorporating the Rome 4 criteria, and proceeding with a selective limited laboratory evaluation. We do have prescription medications available for the treatment of IBS. And so, again, our secretogs, linaclotide, flecainide, lubiprostone, and our retainagogues, tenapanor, first in class. Really, we're wanting to focus on enhancing the response to over the counter therapies and prescription agents, ensuring an adequate trial, confirming adherence. Maybe we dose adjust the therapies. And then lastly, incorporating that multimodal treatment approach. And that's really supported by that therapeutic clinician patient relationship and calling upon our colleagues to help as well. So, I have a few questions here that I want to take an opportunity if we have a minute or two. There's a question related to at what point should a primary care provider refer a patient with IBS-C to a GI specialist? And I think it's important to recognize that, as we're doing our positive diagnostic strategy, our history, and our physical, if it is such that there's an atypical presentation, we want to refer, we want to follow up on that. If in our initial evaluation, there's evidence of iron deficiency anemia or an elevated C-reactive protein or abnormal celiac serologies, referral. But also too, if you have a patient who has refractory symptoms, that would be also important to refer over to gastroenterology. Um, Another question related to, well, why would we not just use PEG to treat IBS-C? And again, it's important to recognize that polyethylene glycol can be helpful in the management of bowel symptoms, but maybe less effective when it comes to constipation or when it comes to abdominal pain and bloating. So we might consider, doing some supplemental therapies. You could have a patient that does maybe psyllium followed by, psyllium before dinner, and then maybe they're doing polyethylene glycol thereafter. So with that, our time is up. So I want to thank you all for your participation today, and I look forward to joining you on another Medscape education event. Thank you.